Today we are going to actually have our last lecture for AMP. Yay! So after today's lecture, then you are going to only have to worry about the last lecture exam, lab exam, and the final exam. Well, actually also the disorder presentation. Don't forget about that. So during last lecture, we went through all the developmental stages of developing initially fertilized egg, then embryo, right, then fetus. And we talk about, over the 3 trimesters. Get familiar with those terms, right? Trimesters, or the division of pre-embryo, embryonic stage, and fetal period. Then the fetus become bigger and bigger, and the last 2 months is where it gained most of its weight, right? By the time then it's ready to get outside of the pregnant mom, right? So then now you are going through this stage. The mom is going to go through this stage of going to labor and deliver the baby. So that's what we're going to focus on for the first half of today's lecture. And then we're going to talk about heredity, the genetic, features, the genetic traits. Well, then how the labor starts, right? We know, there's a lot of things we don't know. What exactly triggers, when exact timing of the labor. But what we do know is estrogen. Remember the estrogen that actually have a really high level at the later stage of the pregnancy, right? Estrogen and oxytocin both promote the contraction of myometrium. This is the middle layer, right? The muscle layer of the uterus. Right? The inner layer is endometrium. The smooth muscle layer is myometrium. And then progesterone is the other major sex hormone, right? Also, that's the one that counteract the effect of estrogen. So it relaxes myometrium. So it's a balance, right? Throughout of the pregnancy, then you have both high level of estrogen and progesterone. So one promotes contraction, one relaxes the myometrium, so it achieves the balance. But then when it's getting closer, right, to the laboring, the balance, there's additional hormones come into play. So there are two kind of labors, right? One, you probably have, if you have experienced, from your friends, family, or yourself, you probably have heard these terms before, right? One is called false labor. So that's basically during the false labor or Braxton Hicks contraction, right? The uterus start to contract, but then it's not regular contraction, and the contraction tends to be relatively weak, right? And it's irregular, meaning it doesn't come to be very often, right? You probably heard about, if your contraction is, every 5 minutes. So that's very frequent and regular contraction, right? So that's a sign. If your contraction is every 5 minutes, that's a sign you're going to true labor, right? So apparently then the big difference, distinguish feature between the false labor and true labor is the frequency, as well as whether it's irregular or regular. In addition, there are other things associated with the false labor. So the pain could be felt differently. The pain is more localized in the false labor in the pelvic region, and they may stop. Or if you probably have heard about, you should get up and walk. So if you walk and then somehow, or if you change your body position, somehow the contraction, the pain feels better, that's not a sign of a true labor. That's a sign of false labor. Because the pain actually responds to your body position and movement. So the opposite side opposite is true for the true labor, right? So the pain is not going to be alleviated because of your body position change or your movement. And so that will be indication of true labor. And true labor also have this pain, not only including the lower abdominal region, but also a lot of times related to the lower back, right? And the pain the contraction tends to become regular and more frequent over time. There are 3 stages of true labor. So the first one is dilate stage, during which stage the cervix dilate. So we're going to see a diagram of that. But then the other 2 stages are expulsion stage and placenta stage. Basically correspond to expulsion of the fetus versus expulsion of the afterbirth. Okay. So let's look at what initiates the true labor, right? So this is a collaboration actually between the mother and the fetus. It's not only driven by the mother. And this process involves feedback. And you probably realize there's only green arrows on this feedback loop, right? So this is different from most of the diagram when we talk about inhomeostasis in this course, right? Because usually you can see green and red, and being red being indicating inhibitory effect, and the green arrow indicating stimulative effect, right? If you see green and red, that usually means that's a negative feedback, because then the final effector will oppose the changing in the opposite direction of the stimulus. So then will be inhibitor to the stimulus. Therefore, it's a negative feedback. But here, everything is red, is green arrow is stimulative. That's a positive feedback. And it's driven by a positive feedback of oxytocin, and the oxytocin comes from both the fetus and the mother's hypothalamus. Remember, oxytocin is produced in the hypothalamus but released, right, in the posterior pituitary gland. Right, this is actually comes from both. So let's go through there's multiple stimulus effector stimulus here. I'm going to take time walk you through every single one of them. Why do I do that? It's because, you should expect to see this diagram in the exam. Okay, so you need to be able to actually describe this, make sense in your own language. So then you can basically when you see this diagram in the exam, you can do it correctly. Okay, so let's start here. Stimulus here is oxytocin from both the mother and fetus, right? And then the effect of oxytocin. So oxytocin, as we talked about in the last lecture, so it's actually it's a hormone that's stimulating the contraction of smooth muscle in the uterus, right? So then it not only that's stimulating of the smooth muscle. That's one side of it. So that's one side of stimulating the uterus to contract, right? The other stimulation of the oxytocin is for the placenta to make this localized hormone called prostaglandin. Prostaglandin, we have actually mentioned it a couple times in AMP. Usually it is a factor, right? An inflammatory factor involved in inflammation. But for the fertilization to happen, the prostaglandin secreted by the sperm actually going to also in the semen, right? Also going to help the sperms get into the cervix. So there's a couple more places other than involved in local inflammation. So here's another example. The placenta can make prostaglandin. So what's the focus, what's the effector for that stimulus, right? So that prostaglandin is going to act as a stimulus and stimulate also the contraction of the uterus. So you have the contraction of the stimulatory effect from prostaglandin, also the stimulatory effect from oxytocin itself, right? And so then work on the uterus. Effector is uterine here, right? So the uterus are going to contract even more, right? You're taking double whammy. And then so the contraction of the uterus is going to push the fetus, right, to push the fetus down and towards the cervix. And the fetal head, so it's going to push the cervix to become thinner, right, to dilate and to be stretched out. And when the cervix stretched out, it becomes thinner. And then the dilated cervix, now actually there's receptors there, right? Then it's going to relay the signal, right? The cervix is dilated and stretched, and then to the hypothalamus. And the hypothalamus now of the mom is got that signal, right? The control center is the hypothalamus and the fetus hypothalamus, and then both going to secrete to give the signal to the posterior pituitary gland to secrete oxytocin, to secrete more oxytocin. So then you can see as this cycle goes, then the result is more oxytocin secreted, more contraction, and the contraction push the fetus down, and cervix get stretched out even further, and then more the hypothalamus is going to take it as a signal as more oxytocin, right? So the contraction, that's why the contraction becomes more frequent and stronger, right? Because of the work of positive feedback loop of oxytocin. Let's look at the 3 stages of the true labor, right? We talk about the first stage is the dilation stage. That's the stage actually the longest stage, right? It's also the stage that, depending on whether this is your first baby or is it your 5th baby, it varies. The length varies dramatically, right? So during this phase, what happens is actually you begin with the regular uterine contraction. That's the definition of basically true labor, right? Then when do we say it's the end of the cervix? Well, that's basically, you should be familiar with this term called a phase. A phase is the whole cervix, right? Is basically thinned out and dilated. Basically it's thinned out, become very thin, right? And not only that, if the cervix is effaced, but also dilated to 10 centimeter. So this is showing you partial dilation of the cervix, and then a full dilation to 10 centimeter. Why 10 centimeter? That's because that's how wide your cervix need to be for the fetus to be able to come out. The head of the fetus is the widest point, right? You need that wide. You need the cervix to be that wide for the baby to come out. And also associated with the end of dilation stage is usually during this stage, then the amniotic sac, right, surrounding the fetus has to be erupt, and also the amniotic fluid that in the sac, right, is usually going to get out too. So if it's not, so that's usually what we say water breaks, right? Sometimes you need to manually erupt the water, basically the amniotic sac. So then to help the labor going to the next stage. So this is showing you the dilation stage. Then the next two stages are here. So expulsion stage, right? Here during the expulsion stage, you basically expel the fetus. So you started with crowning. So that's the emergence of the fetal, the top of the head calvarium, right? The fetal you can see the calvarium of the fetus as crowning, and then you're followed by the expulsion of the the baby's head, and then followed by the rest of the body. So that's the expulsion stage. The last stage is placental stage. During this stage, the uterus still continue to contract, and then during that contraction, cause the placenta to detach from the uterus. And so why that is important, and furthermore, then the uterus is going to be also going to be expelled from the uterus. Why that is important is because not only, so that's why we call it afterbirth, right? Not only have your placenta there, but also all the remaining of fetal membranes. Remember, we have also have the embryonic sac, right? So if it has to be, all of that has to be expelled from the uterus. If there are residual fragments, right, left in the uterus, that could cause complication of the such as hemorrhage, because that's considered foreign, right? So that will be anything that's remaining in the uterus will be considered by the mother's body as foreign and could cause damage and other foreign response to the foreign substances in the body. Okay, so then we're going to follow something about. Let's first follow about the changes happen for the newborn, right? So when the baby is born, a couple things would have to happen. Right, the two major changes will be first on the respiratory system. Right, when the baby is inside of mother's body, the baby do not have to breathe on their own. They get all the respiratory gases from placenta. Right, remember, placenta is where you have the exchange of respiratory gas. You have the umbilical artery, right, that's being carrying the deoxygenated blood from the fetus to the placenta and get reoxygenated, right, get oxygenated, then become umbilical vein, right? So that is what happened, right, in the fetal stage. But now with a newborn, right, then the baby would have to breathe on them own. So then usually the baby would take the first breath within 10 seconds after birth. And that's the responding, that's the baby's response to the changes in the environment and the temperature usually. I know traditionally, when the baby is born, midwife or nurses or doctors tend to spank the baby on the belly, and then the baby takes the first breath, and used to be think, oh, that's because you use the spank, right, to trigger the babies to respond, and so they cry, then take the first breath. Actually, that's not necessary. If you don't spank the baby, it is also going to take the first breath in 10 seconds. So that's something is called association, right, but not triggering event. So turns out that spanking is actually not necessary. And during that first breath, the lungs become inflated for the first time. And then, so basically then you have increased pulmonary pressure because of inflated lung. And so that's going to then change also the circulation system. Because we actually talk about the circulation system, the difference between the fetal circulation and regular, right, circulation, when we were learning about the cardiovascular system, right? So during the fetal circulation, there's a shunt, right, between the two sides of the heart. There's also another shunt between the arteries and veins, the aorta and the pulmonary artery, right? Because the fetal circulation didn't need a pulmonary circulation, but now the baby actually needs a function of pulmonary circulation. So the increased pressure in the lungs is going to help establish that. And also this hole in the heart, right, in the atrium, is also going to be closed. Remember that was a flat, or originally it's a foramen ovale. There's a oval-shaped hole, but then it's going to be closed and become a fossa, right? Fossa ovalis. So, and all those shunts, right, the connection and the placenta becomes irrelevant. It's going to be actually clamped off, right? So, and cut. So the umbilical cord is going to be cut, and so that's there are other changes. All that where the umbilical cord, right, gets into connect to the fetal circulation through liver, that's going to be irrelevant and regressed. And so that shunt here is also going to regress between the aorta and the pulmonary artery. And so there's big changes in this circulation system. You do not need to memorize any particular things, but it's good for you. It's kind of connecting, okay, why, basically building the connections with what we learn in the respiratory system and this cardiovascular system, tie it here. But you do not need to worry about too much about specific structures on this diagram. So clinical view, right? We want to actually want to talk about is the inducing labor. So sometimes, right, there are still a lot of things we don't know about what triggers labor, but we do know, right, is oxytocin the positive feedback of oxytocin can actually initiate true labor. And so that's what we use in terms of, if the baby is past due, 2 weeks past due date, right? The baby becomes too big, still would continue to grow inside of the womb, and that may become too big, right, for the mom, so increase the risk of laboring. And so and then usually you can schedule, if this is the case, then you can schedule an induced labor. And then what the doctors use to induce the labor is first prostaglandin gel, right, insert with the cervical dilation, but also IV synthetic oxytocin. So because then we know once you kickstart the system, then it's going to become a positive feedback, right? So if for whatever reason the initial oxytocin trigger isn't there, you can manually giving that trigger. But this oxytocin level has to be very, very tightly controlled, because you do not want, because the oxytocin is going to induce the contraction, right? You don't want to give a really high dose to begin with. That could cause a problem with interfere with the delivery, the laboring process. So it has to be usually administered by a pump, tightly controlled, how much is given over how long time period, and the doctors can keep monitoring. And once the true labor is starts, right, then depending on the situation, then they can tighten it back, or they could still drip in a little bit of oxytocin just to keep the process going. So this is, something you actually, it's not as simple as just, throw a bunch of a lot of oxytocin. The amount of oxytocin is important for the safety. And now we're going to look at what are the changes in the mom, right? After the delivery, if you still remember this, right? The hormone levels we talk about, there are a lot of pregnancy hormones circulating high in the mother's body, and it's very high level, especially in terms of the progesterone and estrogen level. It's right here, right? And then after the birth, because they come from placenta, and the placenta is expelled from the body as after birth, then you see the hormone levels plummeted, right? Just within a couple days, straight shoot down. So that's actually causing in addition to estrogen, progesterone, there's also the CRH and aldosterone, right? Remember all the hormones. CRH works on the pituitary gland, right? And then on the adrenal gland, which secrete aldosterone. And so that's going to cause dramatic change in the mother. First thing, blood volume and fluid balance is going to change. So associated with right after the birth, the mother, the new mom now, usually have heavy bleeding. With shedding of all that hypertrophied endometrial tissue, because endometrial layer hasn't been shedded for like 9 months, right? And that was for this support. That was to support the development of the fetus. Now the baby is born, then the mom's going to actually have to shed all that endometrial tissue, so associated with heavy bleeding. So you're going to lose blood there. But in addition, so that's called low share. And in addition to that, because remember with the help of aldosterone, the pregnant woman increase the blood volume, right? By keeping the fluid in. Now, all that hormone is gone, and so you're going to actually dramatically increase the urine output, because you're reducing, right? The aldosterone is going to help you to keep the to keep reabsorb, right, the filtrate. But now you do not have that much aldosterone anymore, so you're going to actually get rid of a lot of the body fluid by frequent urination, but also profuse sweating. And so all of that helps you, the result is reduced blood volume, right? And with reduced blood volume, actually associated with it, that is going to be reduced blood pressure, right? Remember, the blood volume always are directly positively related to the blood pressure. Pregnant women tend to have higher blood pressure because they have higher blood volume. Now the blood volume is down after the birth, after the delivery, after the labor, then the blood pressure tends to be lower too. And then there's another major change in the new mom is then the body of the mom start to get ready for lactation, and that will be milk production and release. Right, so the initial milk production is not really milk look like. It's kind of a thickened fluid. It's called colostrum. So it's really actually rich in antibodies. So that's really passing on the immune kind of the antibodies to the newborn, so then they can be protected at least for a few months. Right, and the lactation itself requires both the prolactin and oxytocin. So oxytocin again here is for milk ejection, and importantly it is maintained. The lactation is maintained by regular breastfeeding. And if some of the moms, for whatever reason, or sometimes it's the baby couldn't latch on, having problem of regular breastfeeding, then the lactation feedback loop is going to be stopped, and then it's actually not going to be the milk production wouldn't be able to be maintained. So this is, again, breastfeeding is actually maintained by positive feedback. We're going to see that in the next diagram. Another major change for the mother would be the uterine. So uterus has grown, right, tremendously during the pregnancy. Hypertrophy and hyperplasia, we talk about, right? Both happen. And then the uterus would have to return to normal size in 6 weeks. And that's also with the help of oxytocin. Where does oxytocin come from? Well, from the breastfeeding. With each breastfeeding, you not only work on the milk ejection on the mammary gland, can also help the uterus to contract, right? And to actually each time going to be further contract, and so until it returns to normal. See what is the regulation of the lactation, right? So we start with the stimulus, which is the infant suckling, and so that's a stimulation that going to be detected by those receptors on the nipple, right? Mechanoreceptors. And the nipple is going to relay the information, right, to the hypothalamus, and so then that's the hypothalamus going to respond. That's the control center here, right? In response to that signal, the hypothalamus is going to produce oxytocin, and basically work on the oxytocin is going to work on the mammary gland, and for the mammary acinar cells, right, acinar cells to contract and then eject milk, right? So that's a positive feedback, right? The eject milk, then the baby's fed, and the baby got milk, and baby continued to suck, and then this feedback keeps going, right? There's another response, right, from actually the suckling is going to the hypothalamic neurons, but then those are the neurons in the hypothalamus that release the prolactin inhibitory hormone, is also called dopamine. So that's actually an inhibition, right? Inhibition of the inhibition. So inhibition of the inhibition results in then the prolactin is going to be secreted by its anterior pituitary gland, right, to secrete prolactin. So then the prolactin is secreted and then work on the mammary glands, and then the mammary gland is going to produce breast milk. So that's why you can see here, looking at the prolactin level, right, is also high in the later stage of the pregnancy, but then after the birth it also plummeted. But with each breastfeeding, you can see the spikes of the prolactin level, and that will be enough to maintain the milk production. You do not need continuous high level of prolactin, but those spikes would cause it would be enough for the mammary gland, right, to get enough prolactin and to keep on producing breast milk. And if they keep promoting breast milk, then the baby can be fed, and the baby then can so then when the baby stops nursing is when baby is fed and is going to stop, is full, and then it's going to stop suckling, then you stop this process, right? So it's a positive feedback. The nursing part itself is a positive feedback, and the production of the milk is kind of it's a half of a loop. It's not a continuous loop, but it's relying on the nursing, right, to generate enough prolactin level, enough prolactin to keep the milk production going. Okay, that is all for the delivery labor and lactation.